Increased donor availability, the advent of reduced intensity conditioning regimens and improved supportive care has meant that allogeneic stem cell transplantation now plays a pivotal role in the management of many fit adults with acute myeloid leukemia. And yet, despite the fact that allografting optimizes anti-leukemic activity, is associated with improved outcome, disease relapse is still destined to occur in between 30 and 70% of patients. And there is therefore a huge imperative to develop strategies that reduce the risk of disease relapse or alternatively treat relapse more effectively. Azacitidine is a promising agent in both of these areas of considerable unmet need. To deal briefly with the first, there is now clear evidence that post-transplant maintenance with azacitidine is deliverable, and there's some scientific rationale to suggest it may optimize a graft versus leukemia effect by upregulating the expression of epigenetically silenced tumor antigens that are recognized by donor T cells in the graft versus leukemia effect. However, there's very little data, in fact none, to confirm that post-transplant azacitidine maintenance does improve outcome or reduce the risk of post-transplant relapse. In the UK, through the Impact Transplant Cooperative, we are about to open the first study looking at oral azacitidine post-transplant as maintenance therapy, a study called Amadeus. It's going to randomize 320 patients to get post-transplant CC486 or a placebo after an allograft for AML. Azacitidine also shows real promise in the management of patients with recurrent disease. At present, there's no definitive approach towards managing disease relapse, but we know that if you can get patients back into a second remission, they can often have a significant prospect of long-term disease-free survival if they're given DLI in their CR that they have achieved, or even they can go on to a second transplant with curative intent. Azacitidine is an agent that shows considerable promise in this area, and we in the EBMT group analysed 180 patients who had azacitidine salvage for post-transplant relapse, and we were able to show clinical responses in about 30% of patients. Patients who relapse beyond 6 months post-transplant, patients with less than 20%, blasts at the time of relapse, patients transplanted for MDS as opposed to AML, and patients who were transplanted who were in remission at the time of transplant, all do better with post-transplant AZA. And so in a selected population of patients, particularly those who relapse beyond 6 months, there's a real utility for azacitidine. And our group has also been interested to ask whether you could use lenalidomide as a strategy to augment the effect of azacitidine salvage therapy. Lenalidomide, of course, activates T cells and therefore may act synergistically with azacitidine to augment a graft versus tumor effect. And we've just published in the JCO a study called Viola, which has established that it's possible to give safely quite high doses of lenalidomide, up to 25 milligrams, with no significant increased risk of GVHD, and what would appear to be a promising uplift in the CR rate. These data need to be confirmed in a prospective randomized study. The alternatives for managing patients with relapse post-transplant are intensive chemotherapy, which is often ineffective and most patients don't understandably wish to go through, but also importantly in patients who have a FLT3 mutation. There's some quite encouraging data from the Quantum-R study and the Admiral study that these patients may respond either to quizartinib or gilteritinib as salvage therapy. And the pivotal feature of the use of salvage therapy, of course, is that if patients get back into remission, then we can think about giving DLR a second transplant with curative intent. So this is a promising agent in this sphere, but we need to think about how we optimize the activity of azacitidine.